her video going, we can go ahead and get started. Welcome, everyone. Thank you so much for joining us tonight for Women in Wine, a women's IBD education program. I am so excited to host all of you tonight. We did our inaugural women's education program last year called Brunch and Bubbly, and obviously in the wake of the pandemic, we had to figure out another way to come together and be together and connect. So thanks for joining us virtually. Just wanted to make sure that you guys, just a couple of housekeeping items. Please remain on mute during the presentations when Dr. McCutcheon and Allison are presenting. Stay on mute, please. On your toolbar, you should be able to submit any questions that you might have for them into the chat box. If you would rather your questions stay anonymous or private, you can email them to me. I'll have my phone in my hand and checking my email. My email address is mball@crohnscolitisfoundation.org. And I'm also going to put my email address in the chat box, so you can click on it in the chat box. If you know how to do private messaging in the chat box, you can also message me privately and I can ask the question for you. This program, the presentation portion by Dr. McCutcheon and Allison is going to be recorded when we go to our breakout sessions, which will be the age group that you chose when you registered. That will not be recorded. That is going to be discussion based and is going to be a private and confidential conversation between us. So just so you know, that part will not be recorded. The Crohn's and Colitis Foundation has a lot of resources right now, particularly virtual ones for all of our patients. You can go to our website and find all of our patient education, support, and advocacy resources at crohnscolitisfoundation.org. And just a reminder, today is the first day of Crohn's and Colitis Awareness Week. Awareness Week is from December 1st through the 7th. So if you're on social media, like our page and participate in some of our Awareness Week activities that we have going on. We have a lot of events and a lot of support groups and education events that we are hosting virtually for the next couple of months. You can look at our local website, crohnscolitisfoundation.org/chapter/Georgia, to check those out. And if you need to contact me about anything or have any questions, that's what I'm here for. Please reach out to me, or you can reach out to our IBD Help Center at any time of the day. I'd like to thank our sponsors for our program tonight: Atlanta Gastroenterology, which is part of United Digestive, UCB, and Janssen. They all sponsored us financially to make this program possible. And now I would like to introduce two wonderful volunteers, Dr. Asia McCutcheon, who's an adult gastroenterologist in Brazelton, Georgia, with Atlanta Gastroenterology Associates, and Allison Moe, a physician's assistant who works with Dr. McCutcheon in the Brazelton area. So to stop sharing my screen, Allison, I'm going to share your, just FYI, I see you perfectly. You look great. So I'm going to turn it over to Allison. I cannot see her at the moment. And she's sharing her screen, so I'm going to mute myself and let Allison present.
Hey, everybody. How are you this evening? Thanks for coming in and giving us your ears. Like Mary said, my name is Allison Moe. I work with Atlanta Gastroenterology, and I've been with Atlanta Gastro since 2008, and I have a special interest in IBD, and particularly women in IBD. So this evening, I'll be going over women's health and inflammatory bowel disease, particularly the pre-pregnancy years and pregnancy years. And then I'll be followed by our guru, Dr. McCutcheon, for the post-pregnancy years. This should really be an informal presentation, so feel free, I know you're all muted, but feel free to put a little chat message if you have any questions as I'm doing the presentation, so that we can address your questions when we're all done. Okay, can everybody see this presentation? Okay, perfect. All right, so as Mary mentioned, these slide decks were compiled from previous physician and research data, and I'm happy to present that information. Thank you to Takeda and Janssen and AbbVie for their assistance with all of this info. Currently, between the United States and essentially Canada, we have about almost 2 million cases of inflammatory bowel disease. We diagnose about 75,000 cases yearly at this point. You can imagine that that's much more now than it was years ago, because we have so much advanced testing and patients who are much more aware of family history, etc. The peak incidence, which means the average higher ages of which the disease is diagnosed, is usually between either the late teens or early 30s. We are seeing people diagnosed even in the later decades, 50s, 60s, and 70s. But again, the peak incidence, which is the most common age range that we see this disease being diagnosed, is in the late teens to kind of early 30s. About 20% of patients are diagnosed before the age of 20. And usually the spread between men and women is essentially 50 and 50. When we're talking about our women pre-pregnancy years, we're obviously talking about the kind of juvenile and adolescent years. And some of the things that we see and could be symptoms of early inflammatory bowel disease are complaints of abdominal pain, fatigue, avoiding eating certain foods because of postprandial, which means after eating pain, and growth failure. Being low on the growth charts is usually a high indicator of potentially some nutritional or absorbency deficiencies. Typically, we have B12, iron, vitamin D deficiencies. That usually has to do with a lot of where the Crohn's disease is located in the bowel, in the later part of the small intestine. Usually, many of these vitamin deficiencies occur. And some changes that we may see are constipation versus diarrhea, depending on the severity of inflammation, some transient lactose intolerance. Some people also may have some intermittent gluten intolerance, and some intestinal barrier function, which may be secondary to some breakdown of the mucosal wall, which is part of the theory about why some patients may get inflammatory bowel disease. As we mentioned on one of the first symptoms for growth failure or development, sometimes that's because of reduced calorie intake, because of a food phobia, or people having pain after eating, so they reduce the amount of food that they can actually take in during a meal. Chronic inflammation of the bowel can cause growth delays. Chronic steroid use, we all talk about how being on short little bursts of steroids is okay to help get inflammation under control, but it should not be our long-standing maintenance therapy, because it can cause growth development issues. And patients may have delayed bone age or early osteoporosis findings, psychosocial impact, including growth delays, girls potentially not hitting puberty, or having less of a developmental getting less developmentally advanced compared to their peer population. And obviously, particularly in women, although this affects both sexes equally, women tend to be more conscious of some body image changes, being unbelievably thin, being underweight, potentially not having menses the same as other women. These are all things that in the early puberty years are what teens and the adolescents look for in being common with their peer population. So it will have a big psychosocial impact. Irregular periods are very common, and that's usually because of either active inflammation from uncontrolled inflammatory bowel disease or because of significant weight loss. The other reasons may be because of some medications. Oral contraceptives, steroids, antibiotics can also alter the menstrual cycle. In regards to staying on top of and continuing with routine pre-pregnancy screening and health maintenance, the cervical cancer screening should be at age 21, unless the, I don't want to say patient, I hate saying the word patient, but unless the individual is sexually active prior to the age of 21, the previous recommendation was for yearly pap smears, which has now changed to every 3 years if you have had negative ones previously. Any patient who has a high risk of having increased risk of cervical cancer are patients who have abnormal pap smears, who have been on immunosuppressive therapy, who have previously had any increased abnormalities like dysplasia on their pap. And those patients should have routine and yearly surveillance. And of course, over the past several years, we've had conversations about early HPV vaccines in both boys and girls in the prepubescent years. I believe the recommendation now is as early as 11. Besides cervical cancer screening, we talk about bone density and calcium and vitamin D. A lot of times in patients who have previously been on steroids, we do have some bone density issues later on. When it comes to, with regards to health maintenance, we always talk about multi-organ systems. And so we talk about cancer screening, bone health, skin, which includes making sure that you are watching for any skin changes, making sure that you're doing the appropriate screening. So applying sunscreen in order to continue with cancer prevention. And in women in particular, we deal with a lot of anxiety and depression because of the psychosocial effects like we discussed on the prior slide. And again, making sure that we're up to date on whatever vaccines are necessary for early women's health. I don't need to go through each of these vaccines individually, and I believe you're going to get the information here, but essentially we want to make sure that we are absolutely up to date on all the appropriate vaccines, because we don't want to have any infection or virus while we're trying to keep our population under good control. There are some exceptions with live vaccines and certain medications that you may be on, and that obviously will be a conversation between patient and provider. As we move towards more of the prepubescent, or I should say pre-pregnancy years, and we move towards fertility, essentially, if you are having regular menstrual periods and you have no severe active disease, there should really be no active moderate to severe disease. You should really have no change in your fertility percentages, which between the ages of 18 and about 28 to 30 are essentially 25% chance of getting pregnant per month with, obviously attempting to get pregnant. Your fertility long-standing should not be changed, and there should be no decreased issues with being able to get pregnant as long as your disease is well maintained. If you are a patient that has irregular menstrual cycles because of low weight, or if you have adhesions or active disease that's causing some intervention or some disease to be involved with some of the GYN organs, then obviously your fertility chances are going to be changed. Potentially having surgery may change your fertility possibilities, but that wouldn't be something that long-standing would affect your fertility possibilities. It would just be something that if you had a surgery at that time, and obviously smoking we can say is a risk for having fertility issues regardless of having inflammatory bowel disease. We talk a lot to patients, especially in women who are in their early 20s who may not be ready to have children, but we talk about what drug therapy we're going to be considering for those patients, because we don't like to change therapies if the patient is doing clinically well. So if you are not at the point where you're considering conceiving, but that is something that may be in your 5-ish year plan, we may change the medication that we would offer to put you on, knowing that in the future, pregnancy is something that you're considering. Versus if you are post-childbearing age, you would be a candidate for different medication options. All right, and that's our pre-pregnancy info. Give me 1 second and let me just get to the...
And everyone, while Allison is switching slide sets, just want to make sure you know that you should be able to answer questions or leave comments in the group chat. So if you have any questions, Dr. McCutcheon is actively answering questions as participants type them in. And also if you have one you want to ask anonymously or privately, you can email that to me, and I am putting that in the chat box right now.
I am working on getting this second presentation open. Sorry, give me 1 second.
Take your time. There's no hurry. We're okay.
I knew with the first one being so easy to move that there had to be some hiccup.
You did so good.
All right.
And while we're waiting, if you registered before Thanksgiving, I don't know if you can see this because my background keeps making it disappear, but if you were able to sign up before Thanksgiving, you should have gotten a Crohn's and Colitis Foundation wine tumbler in the mail. If you didn't, you can privately message me and I'll make sure that I mail it to you. If you did register between Thanksgiving and today, I have your mailing address and there's one in the mail to you. But you can fill it up with wine, water, tea, whatever you like.
All right.
There you go, Allison.
Here we go. All right. So we've kind of gotten our information about what we're thinking pre-pregnancy, and now we're going to talk about our pregnancy and IBD. So obviously we're talking about the female population here only. We talked about IBD affecting about 1.5 to 1.6 people in the Northeast part of the world. And like I said earlier, it's about a 50% men versus women. So we've got about 800,000 US females affected currently. The peak incidence is, again, sometime between the late teens to early 30s-ish, and most carry a diagnosis during their reproductive years. Of course, our plan and what I had just started talking about is we want to kind of really guide the diagnosis and treatment in the pre-pregnancy time through the most common age range, so that we can guide and make sure that we have healthy moms and healthy babies. We'll talk a little bit about inflammatory bowel disease in pregnancy, risk and fertility, medication management, delivery, and then kind of some postpartum discussions. Inflammatory bowel disease requires there to be a multidisciplinary approach, whether you're a pregnancy and childbearing aged woman or if you are a 50-year-old man. But in particular, when we have pregnant women, we really try to be multidisciplinary with a possible maternal fetal medicine specialist and potentially some perinatologist, nutritionist, a lactation consultant, obviously a gastroenterologist, if necessary, a colorectal surgeon if a patient may have fistulizing disease or if they've had any surgeries in the past. If you are of childbearing age and really are planning to get pregnant, that would be something that I would be having a conversation with your GI and your OBGYN, if possible, prior to the planned conception. We want to make sure that your disease state is under control, which means we would rather you be as well controlled from an inflammation standpoint as we possibly can in order to make sure that the woman's body is going to be as well of a vessel to carry that pregnancy as safely as we can. There's a risk for low birth weight infants. If mom has low birth weight or nutritional deficiencies, there are risks for possible premature delivery if the Crohn's or ulcerative colitis is not under control. Moms who may be with low weights and nutritionally deficient may have issues with appropriate weight gain during pregnancy. The average okay weight gain is anywhere between 15 to 25 pounds. And then, of course, with labor and delivery, we can have issues with placental abruption, which is where the placenta kind of disconnects from the uterus. There is possibilities that you may be an increased risk of having a C-section instead of a vaginal delivery. And certainly preeclampsia, which is an elevation in blood pressure, amongst other things that may cause you to need early delivery. The American College of Gastroenterology or the American Gastroenterology Associates Guide on Inflammatory Bowel Disease and Clinical Decision Supports when we're talking about preconception and then your 9-month pregnancy plan and then delivery and postpartum shows, the things that we've mentioned: disease management, medication management, making sure that we have an interdisciplinary approach. And then during your pregnancy, making sure that your nutrition is appropriate, you're having the accurate and appropriate amount of weight gain, and monitoring your inflammatory bowel disease. The delivery being either a routine vaginal delivery or C-section. And then postpartum, making sure that we continue with disease management, contraception, post-delivery, lactation, and making sure that baby is okay. I just want to touch base on this one part. Most moms, or I should say most pregnant women, your body is a very smart vessel, and it usually does a very good job of staying with no active disease during your pregnancy. It is the post-delivery part that we worry a lot in moms, causing a lot of inflammation, that we want to make sure we're under good control, which is why medication and staying under control during pregnancy is so important. So, the question of a lot of people and why some people choose to not have pregnancies is because they're worried that they're going to be potentially passing on IBD to their child. And if you have both parents with inflammatory bowel disease, the risk potentially may be more than 30%. But the absolute risk of Crohn's and ulcerative colitis of the mom passing on to the child is actually very low. If you have multiple family members, however, throughout multiple generations that have inflammatory bowel disease, that will put your risk of having a child with IBD up. Healthy women obviously are more likely to become pregnant than women who have active, uncontrolled disease. I think that there was a misconception that for a long time, women who had Crohn's or ulcerative colitis could not or should not get pregnant and have children. And we know that that is not the case. This last statement with inflammatory bowel disease medications do not decrease fertility is absolutely correct. What decreases your fertility is not having your disease under control. With Crohn's disease, you may have decreased ovarian reserve. You will certainly have hormonal changes that may lead to a decrease in egg production. And you may have less success with IVF secondary to hormonal issues if your disease is not under control. We talk about age, whether you have ulcerative colitis or Crohn's disease, if you've previously have had surgery, whether or not you've had unsuccessful conception for greater than 6 months, irregular menses. These are all things that would put somebody in the category of not being able to conceive on their own and needing something called ART, which is assisted reproductive technology. I, in my experience, am happy to say that most childbearing women that we have taken care of actually, once their disease is under control, did pretty well of getting pregnant on their own. Hormones used in reproductive technology do not seem to increase any IBD activity. And once pregnant females with UC and Crohn's, females with UC and Crohn's have equal chances of normal live births with the general population. So again, it's all about disease management pre-pregnancy. When we're talking about preconceptual planning, again, this is something that we want to know: what's your disease state? What active disease do you have? What medications are you on that should or should not be used during pregnancy? Have you been up to date on all of your vaccines and all of your pre-screenings? Are your vitamin levels appropriate? Do you need to be taking different prenatal vitamins or additional prenatal vitamins than a woman who does not have inflammatory bowel disease? Getting pregnant would be something that we in general would say we would recommend in somebody who has been at least on maintenance therapy doing well for 3 months, making sure that they are not actively needing to be on high doses of steroids because of uncontrolled disease. And on certain medications like methotrexate, for example, which is not safe to be used during pregnancy, we want to make sure that there's been at least a certain period of a drug holiday before there's any plans for conception. A lot of the medications that we are using now, which are called biologic drugs that you all have seen commercials for on TV and probably are taking yourselves, those medications in general are completely safe during pregnancy. And we want to keep moms with their disease under control, which will increase the chances of having a normal, uncomplicated pregnancy and delivery. So this overall 9-month plan with IBD remission and medications and an IBD flare, essentially this is a graph covering exactly what we've just talked about. Making sure that we're doing appropriate IBD monitoring prior to getting pregnant, making sure that we have the appropriate maternal fetal monitoring, taking the appropriate steps to make sure that our nutrition and pregnancy weight gain are under control. And if there is some IBD flare during the pregnancy, making sure that our medications are adjusted, that OB is involved with all of our decisions. If there's any infectious or changes process, that GYN is also in part of our decision-making with treatment, and then making sure that we're continuing to monitor our fetal growth development. IBD flares will account for about complicating 30 to 35% of pregnancies. There's a higher risk ratio in patients with ulcerative colitis with active disease at conception versus Crohn's disease, about 55 to about 35%. Active inflammatory bowel disease that is not well controlled, again, will lead to premature birth and low birth rates. And then making sure that we have a decrease in our active IBD activity will make sure that we have less adverse events with births and normal healthy deliveries, as well as less postpartum flares. When we assess IBD activity in pregnancy, we're not going to be doing routine colonoscopies and procedures on someone who's pregnant unless necessary. So we're looking a lot more at stool studies, blood work. There won't be any CT imaging that gets performed because of being pregnant, but obviously we'll do a lot of clinical management, symptoms, etc. And then, of course, we talk about the delivery plan, which is most women will have a vaginal delivery unless there's been a pre-surgical diagnosis in which a colorectal surgeon or the OB feels like a cesarean section would be more controlled. Obviously, if there's any active perianal disease, a fistula with the rectal vaginal fistula, or any kind of active ulceration, you have a very increased risk of having an increased vaginal tear. And so those need to be controlled with C-sections. And of course, we want to make sure that in somebody who has perianal disease, that we are not doing any kind of injury to anal sphincter to cause issues with that long term, and that we want to maintain any pouch function if you've previously had a J pouch for ulcerative colitis. When we are talking about post-delivery, we want to be resuming our biologic therapy if appropriate, and based on no complications very soon after C-sections and vaginal deliveries in order to prevent any post-delivery flares. The only medication, obviously, we wouldn't do that in are the medications who are pregnancy category X, like methotrexate. Breastfeeding is something that becomes a very common topic post-delivery in many women, and obviously the patient, the GYN or OB and GI should all be part of this conversation. Most of the IBD medications are essentially undetectable in breast milk or in very low concentrations in the newborn patient. So in most drugs, again, the biologic drugs and medications that we have our patients on who are delivering, there is no contraindication for anybody to be breastfeeding. And actually the pumping and dumping recommendation that we do for other medications is actually not what we recommend in patients who are breastfeeding with taking category B IBD medications. Newborn concerns, of course, post-delivery in moms who are with IBD. We want to make sure that, there are no babies who are exposed to medications and have any issues being, newborns. We want to make sure that we have our inflammatory markers under control in moms, because we don't want any inflammatory markers to be negatively impacting brain development in babies. We want to avoid live viruses in children for the first 6 months, if this is appropriate. And obviously, once the baby is born, we're talking about pediatrician and GYN and gastroenterology. So I think that the most important take-home things are, one, we need to be having conversations with everyone prior to you becoming pregnant. If you have active disease, there's a possibility that you may have decreased fertility. Moms and babies, both in utero and post-delivery, do the best when the mom's disease is under control. Most women who have IBD should really have no issues with having a normal vaginal delivery. In general, breastfeeding is very safe while on most medications. If you are a biologic patient, we want to avoid, or a biologic exposed baby, we want to avoid live vaccines for the first 6 months. And post-delivery, we want to make sure we have the appropriate developmental milestones reached in babies who have moms with IBD. Thank you very much.
Thank you so much, Allison. And everyone, thank you so much for all of your really great questions and comments in the chat. And thank you, Dr. McCutcheon, for being so rapid fire and answering all those questions. Allison, I'll give you a couple of minutes and then you can take over. But thank you guys so much. And Dr. McCutcheon, if you need help getting your screen to share, just let me know. Perfect. There you go.
Very good. All right. Perfect.
Yep.
So yes, Allison, you had some fantastic questions, and I wish I could be on all 3 of the breakout sessions, because I mean, there were questions about surrogates and fertility and all of that. So I'll let you scroll up and just correct anything that you may not agree with on there, but really some loaded questions. I'm going to finish off the presentation section by talking about IBD and women's health after the childbearing years. And I hope one of our participants stayed on, because she was postmenopausal and thought that maybe this was not relevant, but I think we kind of take you through the rest of the life cycle on this last piece of the presentation. So for the sake of time, I'll go ahead and get started. We are going to talk about IBD and menopause, iron deficiency anemia, osteoporosis, cervical cancer. I'll kind of breeze through, since Allison has already touched on that in the USPSTF recommendations in terms of pap smears. There was a question about biologic therapy and whether annual versus every 3-year pap smear should be performed. So that's in the chat box, Allison. And then depression, anxiety, and stress. And those are really sort of more recently, there's been a lot of data to talk about and address those mental states in inflammatory bowel disease. So the digestive system, to me, is the most wonderful system outside of the brain, because it's where 80% of your immunity comes from. And it's essentially the second brain, and it spans from the mouth to the anus. And when you're not feeling well in your intestines, your general sense of well-being is significantly altered. And so this is a great depiction of what a person may look like with inflammatory bowel disease versus what they actually feel like. You often feel like, you know, you may look fine, but your body's failing you, and you feel like you're not able to do the things that you should be doing at whatever stage in life you're at. And you also often feel socially isolated and excluded because you're not able to openly discuss these things. And so I love this picture up here too. It says, please try not to judge how someone is dealing with pain that you've never experienced. And so that's absolutely true. We talked about sort of the prevalence of inflammatory bowel disease. It affects approximately 1 million plus women in the USA, and it can impact life, especially after menopause and in the second stage. We know that there's 2 peaks. We have a younger onset of age, and then there's a second peak that actually occurs in people in their 60s and 70s. And so we need to really be hypervigilant about addressing changes in bowel habits when they're presented to us in the office. Many females actually use gastroenterologists as their main healthcare contact. If people don't have anything else going on, we're often the only person that they see every 3, 6, 12 months. And so we have a unique set of concerns that we have to talk about. So people really, when they come in, they want to know, hey, you know what, I'm flaring. Can I have sex? I'm using these enemas right now. You know, that affects my sexual life. I'm getting up in the middle of the night. I'm having painful intercourse. I have these sea time drains in place. All of these things really need to be openly discussed in a supportive manner so that we can address these issues and figure out how to cope with them. There's a great Swedish study looking at men with Crohn's disease and comparing them to women, and women were actually more likely to experience long-term sickness, be on a disability pension, and be single. So women also perceived a more negative impact on their lives from Crohn's disease than the men in the study. So when we look at women's perspectives of living with inflammatory bowel disease, there was a study by Sykes et al. In 2015, really looking at the experiences of women with inflammatory bowel disease and exploring how they manage their disease after diagnosis. And in conclusion, women described trying to change their dietary behaviors in order to adjusting their daily routines, making sure, for example, maybe they stayed home in the morning to try to evacuate the bowels and not go out with their friends, or, you know, maybe have a later start schedule for work. There's a description trying to really sort of self-adjust medications, taking, you know, some people have to take Tulamodal or Imodium in order to leave the house. And so there was data looking at 23 studies, and it really identified fatigue, incontinence, and uncertainty about the future, body image, and lack of information from healthcare professionals as really dominating the experience of patients with inflammatory bowel disease. And these routines that people have of taking these different medications have to be done on a day-to-day basis. And as women, we wear a whole bunch of different hats. I mean, we put on a crown for the kids, or a crown for who we're dating, or a crown for the spouse, a crown for, you know, all these different roles that we play. And I think that when we have this on top of our many different hats that we wear, it can be quite burdensome emotionally. So I'm going to pivot and talk about iron deficiency anemia. The risk of iron deficiency anemia is higher for women that have inflammatory bowel disease than for women who don't have inflammatory bowel disease. And this is because of a higher risk of bleeding in the digestive system. When there's active inflammation, you're losing blood from the inflammation itself. But if there's inflammation, you also have absorptive issues. And the inflammation also affects how the iron is absorbed because of an acute phase reactant. And so we have now identified anemia as a common extraintestinal manifestation of inflammatory bowel disease, which means that it's not sometimes even directly related to the Crohn's or ulcerative colitis itself, but it's a manifestation of the bowel inflammation. And it's associated with a poor quality of life. Luckily now, we know that IV iron therapy is a great adjunctive therapy to help people with their sense of well-being. And just to kind of put this to scale, for every red blood cell, I tell my patients that there are 4 oxygen on each red blood cell. So you're not unloading the oxygen that you need to your different organs in order to be able to function optimally. You'll get more tired easily and so forth. And then the iron preparations that are available that we may recommend actually can cause things to be worse sometimes. So iron therapy can produce abdominal pain. It can cause diarrhea and constipation. Sometimes it's poorly absorbed. And sometimes the iron itself can actually be toxic or worsen IBD activity. And so now we use more of the IV iron, and I can't tell you what a difference it makes in people's sense of well-being when we give them those therapies when appropriate. Menopause. So menopause is basically defined as the cessation of menstrual periods in females who have experienced 12 months of amenorrhea, which means you haven't had any cycle without any obvious pathological cause. And so the median age of occurrence is about 51.4 years of age. There's not a ton of data about the effect of IBD on menopause and vice versa. There's a couple of studies. One was in 1989, so a pretty old study, looking at a survey that revealed that women with inflammatory bowel disease had a mean age of onset of menopause of 47.6 versus 49.6 in a group of healthy women. So maybe about 2 to 3 years earlier, we can expect menopause based on this study to occur in our IBD patients. But a 2008 US study failed to show a difference in the age of onset of menopause in IBD patients with UC and Crohn's disease compared to control. So we know maybe it'll occur a little bit earlier, maybe it won't. There's a host of factors that go into whether someone goes into menopause early or not. And some of those are also genetic that may be kind of skewing this data. Both of these studies are limited by small sample sizes. So what about hormone replacement therapy? There was a question when Allison was presenting about someone being on fertility therapy and really having a rip-roaring flare-up of their inflammatory bowel disease after the hormone therapy was given for fertility. And so there was a 2008 study that found that postmenopausal women with inflammatory bowel disease on hormone replacement therapy were 80% less likely to have an IBD flare-up compared to their IBD counterparts. But hormone replacement therapy is sort of a loaded gun, if you will. It can be great in improving like hair density, your sense of well-being, but the Women's Health Initiative did show an increased risk of breast cancer, coronary artery disease, stroke, and venous thromboembolism, which is like blood clots in patients that, or people that are using hormone replacement therapy. And one of the problems with hormone replacement therapy in IBD is inflammatory bowel disease itself does increase your risk of having blood clots. And so we have to very carefully choose people that we're going to put on hormone replacement therapy. And this is not going to be the same dose that you're using when you're trying to stimulate, you know, follicle growth during IVF, for example. So I'm going to punt that question to Allison Moe and let her take a deeper dive on that in the section. But I thought it was a really great question. There was a 2012 study of postmenopausal women from the Nurses' Health Study without inflammatory bowel disease that revealed that postmenopausal hormone therapy actually may increase the risk of being diagnosed with ulcerative colitis, but not Crohn's disease. So I thought that was very interesting. And the risk of ulcerative colitis increased with the longer duration of hormone use. So one of the responses to that same question was, I'm curious, just really from a personal standpoint, as to whether the person that was doing the IVF therapy actually had ulcerative colitis versus Crohn's disease. So what about osteoporosis? So osteoporosis basically is defined as brittleness and fragility of the bones, and it commonly afflicts patients with inflammatory bowel disease. In fact, patients with IBD are at higher risk of developing osteoporosis, and the stage before osteoporosis is osteopenia. That's the early stages of bone loss, and these are much higher than the general population. And so the risk of fracture in our patients that have inflammatory bowel disease is 40% higher than people that don't have inflammatory bowel disease. The prevalence of osteopenia is somewhere between 22 and 77%. That's the stage before the severe osteoporosis, which still is 17 to 41%. So this is significant. And so we have in inflammatory bowel disease several risk factors that are increasing the likelihood of developing osteoporosis or bone loss. And so it's so much that the American Gastro Association has published guidelines that recommend that we actually screen inflammatory bowel disease patients for known risk factors for bone loss. So if you have a history of having fractures, specifically in your spine, if you're postmenopausal because the estrogen levels seem to be protective, or if you've been on chronic corticosteroid therapy. So if you've had chronic steroid therapy, which is defined as greater than 3 months treatment in your lifetime, then you're at increased risk of having some bone loss. And so the recommendation is if the initial bone scan, which is called a DEXA scan, is normal, then you repeat the test in 2 to 3 years. And these guidelines have helped us to identify earlier patients that have bone loss and would benefit from supplemental treatment. So what are some of the options for prevention and therapy in inflammatory bowel disease? Regular weight-bearing exercise. This probably includes Pilates and all of these bar classes. Using your own body calisthenics is great. Avoiding or quitting tobacco is a big deal. Limiting use of alcohol, that means no more than 2 to 3 units per day. So 4 ounces of wine is enough. You can't have 2 glasses, you can't have 3, and don't order the 9 ounce. Emphasis on better nutrition, particularly on vitamin D and calcium. We often don't get enough sun exposure to convert the vitamin D. And so vitamin D, I think we do a much better job of actually checking vitamin D levels these days. And fall prevention strategies are important too as we get older in our proprioception, which means that our ability to sort of feel the bottom of our feet and where we are positionally at all times can decrease. And so you'll hear like okay, I was at church and I tripped over a pebble. You know, normally you wouldn't trip over a pebble. You know, when you're younger, you don't just trip over a pebble or, you know, roll off the side of the curb and roll your ankle. But as we get older, we become a little bit more unsteady on our feet. So employing fall prevention strategies, making sure rugs are, you know, tacked down and that there's not loose objects, that the kids aren't leaving toys on the floor or grandkids is really important to protect the bones. In terms of therapy, calcium and vitamin D supplementation is important. There's Caltrate over the counter. The recommendations is to have about 1,200 milligrams of calcium and 800 to 1,000 international units of vitamin D. Bisphosphonate therapies, those you may have heard of, like alendronate and some of these ones that you can take every 6 months, every 3 months. There's some IV bisphosphonate therapies. These really prevent you from reabsorbing bone. It's called bone resorption, and they prevent that. Calcitonin is also a medication. We produce human calcitonin, but they get calcitonin from salmon apparently, and that is the one that's given as a supplement. And then we talked about hormone replacement therapy can be helpful to preserve your bone density, but it comes with some potential risks that really need to be discussed in detail. There are some other therapies, parathyroid hormone. That's parathyroid sits behind the thyroid in the neck, and it's responsible for calcium regulation. And so giving you sort of artificial parathyroid hormone, IV, is second-line therapy, and minimizing corticosteroid use or with early use of biologics and immunomodulators. So really not keeping people on steroids, because we know all of the risk of steroids is important for your bone health. All right, somebody talked about sexual health in there, and I really I think this is a great topic. So sexual health is something that is underappreciated and under-discussed when people come to speak to their gastroenterologist about what's going on with them. I always ask patients about fecal incontinence and urgency and knowing where every restroom is, because I know that this can affect quality of life. But unfortunately, based on the studies, not every gastroenterologist is in tune with this. So are you having abdominal pain, diarrhea, fecal incontinence? Do you have a fistula? That's where you have abnormal connections between, you can have them between the vagina and the rectum, and you can actually pass gas through the vagina or have stool coming through the vagina. And you can imagine how that would affect somebody's sexual quality of life. I mean, their body image is immediately, and their perceptions of self are going to be altered by this if it's not something that they receive support on, or the partner is not aware or accepting of what's happening. So these are questions that physicians and healthcare takers, they say typically ask. I say they definitely should ask this every time. These parameters have been shown to have a negative effect on body image and sexuality in women that have inflammatory bowel disease. So in a 2010 study that surveyed inflammatory bowel disease patients on their perceptions about body image and sexuality, 88.5% of both males and females reported impaired quality of life. 50%, so half, had a negative effect on their relationship status. And those that had prior surgeries definitely reported decreased libido, which is your ability to get aroused. Among all females, 74.8% reported impaired body image when compared to men, and a greater proportion of women reported decreased frequency of sexual activity and decreased libido. 20% of women attending an educational IBD seminar survey reported that their GI addressed these issues. So we have so much more room to educate and make sure that providers are actually in tune with the patients and making sure that they initiate and open this conversation so that we can get help early on. So sexual health, you shouldn't be afraid to address these concerns. There are actually therapists out there that specifically specialize in inflammatory bowel disease and working with people that have chronic illness and sexual dysfunction to make sure that these distressing emotions are actually addressed, because these can lead to anxiety, depression, and other mental health concerns. Cervical cancer, I'm not going to get into because we already talked about that, but there was also a big study in 2019 in gut And they basically, in this study, looked at mental illness and inflammatory bowel disease patients. And women with IBD were at greater risk of developing mental illness after giving birth compared to the overall population. We've already heard, we know about postpartum blues, but mental illness is, depression, anxiety, maybe, schizophrenia, all kinds of things were manifest at this time. And 1/5 had a new onset. So they were fine before they had the baby. And then 1/5 had a new onset of mental health diagnosis after delivery. And some of the things that contributed to this altered state included loss of control of bowel, fatigue, impairment of body image, fear of sexual inadequacy, social isolation of dependency, and really concerned about, like, what is my life going to look like now? Am I going to be able to reach my full potential? Can I land that amazing job? There's also problems where people don't feel clean. They're having leakage and they feel like they can't clean themselves. These enemas are all over the bed. They're all over the sheets. That's a big deal. So awareness is very important. People also have fear of surgery. Inflammatory bowel disease, people, when you have inflammation that's uncontrolled, there's increased risk of colon cancer, and you worry about how, what's my lifespan? Am I going to be there for the kids' graduation? Can I see the grandkids? And there's also fear of passing the disease on to children. So all of these psychological stresses and stress changes really can affect your perception of your disease and your sense of well-being, as well as your quality of life. And so it's also been shown that stress increases the risk of IBD flares, and people with inflammatory bowel disease can develop alexithymia. That's where they essentially develop difficulty recognizing and verbalizing emotions, i.e. they check out, or they're a ticking time bomb and can't really control their emotions anymore. So, Gonzala and Kane, basically, when providing an update last year on women's health issues in patients with inflammatory bowel disease, really wanted to emphasize some of the concerns that were women specific, including educating women that menstrual cycle, there was a question about endometriosis as well, menstrual cycle and hormone dependent changes can affect inflammatory bowel disease. Fertility, we need to talk about fertility, as Allison already spoke about, letting your gastroenterologist know when you're about to become pregnant or thinking about pregnancy. It says here that, avoiding methotrexate and thalidomide, those are known to cause birth defects. And Xeljanz is a newer one that we don't want to use when we're going to become pregnant. Contraception, we've talked about. Menopause and hormonal replacement therapy, we talked about. Addressing sexual health and cervical cancer risk. Those were all sort of high priorities on women's health and inflammatory bowel disease and being in tune with these particular things. So I love this. I fight like a girl. This is Crohn's disease awareness. Just know you are amazing. You are a survivor. We are strong. We wear many hats and we can support each other. That's it.
Thank you so much. Oh my goodness.